practices have to use EHRs that are connected with each other and valuable. Meaningful use ultimately is about using data standards and processes along with communication systems to improve healthcare outcomes. These systems are meant to be engaging and to guarantee the privacy and security of health data. The first stage concentrated on foundational items, like simply getting a system in place and preparing for information exchange, as well as converting over to electronic records. The second stage is the one that's about to begin, and it recognizes that patients should be a part of the communications as evidenced by requirements like secure messaging and view, download, transmit, which we'll cover shortly. More focus is placed on structured information like the consolidated CDA standards and information exchange. This stage also increases measurement requirements from Meaningful Use 1 with a continued focus on quality. From what we've seen, the third stage will have even more focus on patient access and involvement, including the possibility of patient contribution and creation of data. There will be more data exchange and structured data expectations as well as quality and safety initiatives for driving improved outcomes. From a patient perspective, you can see the evolution of their involvement in their own care from access all the way to full engagement. We're all familiar with the basic meaningful use timeline. This one reflects where we are today and shows the Medicare timeline for eligible providers. The first note shows that October 2012 was the last date to start meaningful use and get a full payment. That's now passed, but you can still get substantial payments starting 2013 if you haven't begun yet, and we'll look at that on the next slide. 2014 is the first time you can start performing Meaningful Use 2, assuming you've met MU1 already, as early as January 1st, but you must begin by October 2014 if you are eligible to begin Meaningful Use 2. Yeah. 2014 is the only year that will have a 90-day quarter reporting period. If you don't start Meaningful Use 1 in 2014, you'll incur Medicare payment adjustments in 2015 of 1% to start. All payments under the Medicare program will wrap up in 2016. This is the payment schedule for eligible providers under the Medicare plan. The last opportunity to begin a testing for meaningful use is the last quarter of 2014. The column to the right shows that payment adjustments begin in 2015 at 1%, and they're going to increase a percentage point each year up to 5%. As you can see, if you started in 2011 or 2012, your total incentive payments will be $44,000. If you start in 2013, it goes down to $39,000. And if you start in 2014, the total goes down to $24,000. Additionally, you won't incur the payment reductions which begin in 2015. And just a quick reminder to please mute your phones. As a quick review, here's some key dates and items to remember. If you want to participate at all, which it looks like a lot of you have already started, you have to start by October 2014 for Meaningful Use 1. This is the final year for EPs to avoid Medicare penalties for not participating in Meaningful Use. Providers that have met at least 2 years of Stage 1 by 2013 can and must start Stage 2 in 2014. For 2014 only, all providers, regardless of their stage of meaningful use, are only required to demonstrate for a 3-month quarter reporting period. For meaningful use Stage 1, the first year is 90 days and the second year is a full year. But if your second year of meaningful use 1 is falling within 2014, it's still just a 3-month quarter period for you. In meaningful use 2, EPs have to complete 20 objectives. There are 17 from a core set, and you'll choose 3 from a menu set of 6. And October 1st, 2012 was the last chance to start meaningful use and earn the entire incentive payment. This chart shows the total incentive payments for the program as of November 2012. Over 171,000 providers have been paid over $9.1 billion. 5.1 of that was under Medicare, and $4 billion was under Medicaid. You'll see a spike towards the end of 2012, which shows a lot of people trying to get in and meet the deadline to be able to receive the full amount of the incentive payments that are available.
We get these payments?
Three of our doctors, yeah.
Okay.
Dr. Goodell.
This is a summary of the 23 meaningful use objectives, which are divided similarly to how they were in Meaningful Use 1. We have core objectives and we have menu objectives. Eligible providers must choose 3 of the 6 menu items and generally complete all 17 of the core objectives. However, some objectives allow for exceptions to some of the criteria for providers such as radiologists. As I said earlier, the themes of this stage are more patient engagement, structured data, and standards-based communications. We'll be focusing on the patient engagement objectives next, starting with the core patient-specific item of secure messaging. But first, here's another polling question for you. When do you plan to start with Meaningful Use 2?
Yeah.
I think we're good. I axed out before it started to connect to the audio. Maybe?
Oh, okay.
Still is not.
All right, so it looks like the majority of people plan to start Meaningful Use 2 right away. So that's great to see so many people on track. Here's the first of 2 main patient engagement objectives that we're going to take a deeper look at. This will draw your attention to the thing that's been somewhat controversial, and that is that the patient actually has to take action in order for you to receive payment. For this item, the measure requires that at least 5% of unique patients seen must send a secure message within the reporting period. Some practices feel that patient action is beyond their control, but we'll describe to you how this objective can be easily achieved. Looking at that in detail, we'll show what a secure message is, what send means, and what will count towards this measure. A secure message is defined as any electronic communication between a provider and patient that ensures only those parties can access the communication. However, it's noted that the secure message also must use the electronic messaging function of an EHR in order to qualify for the measure of this objective. So using basic email functions won't count. The patient has to do the sending in this case, either through initiation of the message or replying to a message that's been sent to them, such as lab results. The content of the message should be medically relevant in order to count. But it's recognized that an EHR system can't necessarily make that determination on its own. So a portal that guides the type of messaging content can help create more accurate counts. Now, this is the second of the key patient engagement objectives, and it's a 2-parter. It requires that 50% of your patients have timely access to their medical information, and that at least 5% of unique patients must view, download, or transmit personal health information. Both measures must be met in order to achieve this objective. So we have 2 measures here. 50% need access to the information, and 5% have to act on it. Like the last measure, let's examine this in more detail. One has 3 discrete components: view, download, and transmit. And we're going to show you examples of each of these in the coming slides. As stated in the final rule, the goal of this objective was to allow patients easy access to their health information as soon as possible so they can make informed decisions regarding their care or share their most recent clinical information with other healthcare providers. Several elements are in play. Access needs to be timely, within 4 business days. Access is the difference between Meaningful Use 1 and Meaningful Use 2 because now it must be online. The measurement will actually be calculated by the number of CCDs that are electronically sent to the patient. CCD stands for Continuity of Care Document. A visit summary is an example of CCD information that can be sent. CCDs are a structured data format to send a patient their health information. Now, let's dive into some examples of view, download, and transmit.
On my first consult this morning, error.
This is an example of a CCD viewed from our portal inbox. What we've done here is take the continuity of care document that's been received from the EHR and translated it into a human-readable format that is also engaging to patients. Patient Darcy Daggett can see her cholesterol and blood pressure portion of the visit summary from her November 7th visit at the top. Scrolling down will show her all the details in the document.
They like to read.
Please note the download features at the bottom left because we're going to look more closely at those in a moment. Every time a patient opens this view, it will count towards achieving the 5% measure. This measure is a single bucket that contains all 3 actions of view or download or transmit. You saw our buttons at the bottom for downloading on the last slide. The technology we've selected is called Blue Button. Blue Button is an icon that was originally developed by the Veterans Administration to signify a way for patients to get easy, secure online access to their health information. Patients have a right to this information, but they often don't get it because they don't know they're allowed to have it or they don't know how to do it. Through the use of this button icon, so far over 1 million people have downloaded their information from the Veterans Administration. And studies have shown that engaged patients recover more quickly and stay healthy longer. Now we're on transmit. This is the most complicated of the 3 because this describes the patient electing to send their information to another provider or caregiver that's outside of your care system.
Work to make it happen.
We've elected to use a protocol called Direct to do this, which is a secure sending mechanism for health information. The patient would enter the direct address of the physician they want to share with in the box and click Send, which will then utilize the direct infrastructure to send a copy of the CCD securely and safely. Fortunately, View, Download, Transmit is a single measure, and the simplest way to get the count is through viewing the CCD, but any of the 3 actions would count in that bucket. Alternatively, a patient performing all 3 actions still only counts once.
And then you do it. Okay.
I'm going to wrap up with some key takeaways because we've covered a lot of material very quickly. We've discussed the goal of patient action for the first time, along with the increased thresholds for access to personal health information. The next key point is that for those who are eligible to start Meaningful Use 2 in 2014, the good news is that you only need to attest for a 90-day quarter period. This is a one-time break. Beyond 2014, that reporting period is going to be for a full year. Remember, if you haven't begun Meaningful Use 1 yet, there's still time between now and 2014 to get going. We have one more polling question before I hand this over to my colleague, Dr. Warwick Charlton. He's going to show you how you can stimulate patient engagement and action so you can be assured of meeting these measurement criteria. First, we'd like to understand what you anticipate to be your biggest patient engagement challenge.
MU2.
I was in the office, but I won't
Oh, yeah.
That and the adoption.
No. Putting the patients on the problem easy.
It'd really be helpful if everybody muted their phone.
Yes, thank you. Yes, please, everybody mute your phones.
Okay, thank you very much, Jean. Thanks, everyone, for completing that polling question. It looks like getting physicians and getting patient adoption of the portal or engagement are the biggest challenges that people see. And that's what we're going to talk about here for the next 10 or 15 minutes or so. Let me just say to attendees, we're aware that some of the slides are cut off on the right-hand side, but the good news is we'll send out the slides and the link to the webinar to all of the attendees after we finish, so you'll be able to see them uncut off.
Wow.
And just a reminder, if you haven't done it already, to mute your lines. Thank you. So, Jean, I think you made the point well that there is something new in Meaningful Use 2 regarding the requirement for patients to take action and the higher threshold for timely access from the 10% we saw in Meaningful Use 1 to now 50% of a provider's patients having to access their patient information. The good news is we are strong believers that this is achievable, as is Dr. Mostashari from the ONC, as you can see in this quote, although he is focusing on the 5% patient action component. He makes the point that ultimately it boils down to championing the service and reminding patients about the portal and messaging system every time you see them. Well, this slide's key point is your patients are already online, and the numbers are growing. People like having online and mobile options, and they want to connect to their healthcare online too. When I look at data like this, it makes me think of our lives before the internet, which seems like an increasingly long time ago. Can you remember how bills used to come in the mail and we would have to write a check the next Saturday and remember then to mail it back? It sounds funny almost, but there may even be some Generation Y people who've never done that. So things have definitely changed. And the fact is, nearly every day we use online and mobile self-service tools for a variety of things like banking, traveling, shopping, even ordering dinner. It's a huge part of our lives, and we're seeing forecasts now for a doubling of the more than 100 million smartphone users in the U.S. by 2016. And seniors are online too. Both they and many of the disabled find online access more convenient than the alternatives. And this slide here confirms that we're seeing the same thing at Intuit Health, that the number of patients using the patient portal is growing rapidly. In fact, we're seeing over 60,000 patients joining the portal every week, and adoption is increasing. And I think that's a lot due to the fact that as we're moving towards this greater access and Meaningful Use 2, and practices are getting used to talking about it, the momentum is increasing. Okay, so there is action out there, but does it mean that if you have the portal, they will come? And this is a key point because per the Meaningful Use 2 objectives that Jean outlined, 50% of your patients have to have access to an online copy of their health information, and 5% have to take action by VDT or by sending a secure message, So how do you get there? Well, the experience of all of our clients collectively up through 2012 is represented in this slide. This is our prior history, if you will, and it demonstrates that patient access doesn't happen overnight. In fact, it can take many months. even a year or a year and a half to get to 30, 40, or 50% of your patients registered. The good news is we think this can occur faster if the technology is right and if you and the practice are doing some of the right things. I will point out that you don't have to have 50% of patients registered to achieve the engagement metric, but you have to have sent a CCD to 50% of your patients and informed them that it's there and otherwise made it easy for them to access it. So just to put some numbers on registration, we believe that you need somewhere between 20 and 40% of your patients registered online to comfortably hit the view, download, and transmit goal, or meet the 5% send a secure message requirement. So where does all this lead? It leads to the point that patient engagement is not an on and off switch. In order to get usage out of a two-way communication system, both sides have to use it. And this is the key point. Patient registration and utilization is directly related to how much buy-in and support there is from the practice side of the equation. So some key concepts to achieve that are, probably most importantly, that your physicians should be outspoken and active supporters of the technology and its use. They need to motivate each other, motivate the staff and patients, and start using this technology in their everyday and integrating it in their workflows. Same is true, obviously, for the staff. There's some examples of doctors telling patients their lab results will be sent to them online. Have they signed up yet? Answering machine messages, for example, that say, have you tried using the portal for your request? Involving the front desk staff by making sure that they ask if the patient has completed pre-visit paperwork online, or to provide their email address if they have not. I think this is ultimately a story about change. There should be no more status quo. Staff and patients should be encouraged to rethink the way they do things. Use the phone less, use the portal more, and everyone should be knowledgeable about basic portal questions that patients may have. So here's a great client example from one of our clients. I think it's a real-life success story. OBGYN specialists, which is a 13-provider practice in Orlando, Florida. And they believe they have nearly all of their patients registered and using their patient portal. That's about 35,000 patients. They've been very proactive about the way they've gone about championing the portal, and they found creative ways to engage their patients. For example, in these pictures, which I think are cut off, you can see, oh, there they come. You can see that they dressed in Hawaiian shirts to demonstrate commitment to surfing the web. And in fact, you can see Dr. Mervis, one of the physicians there, in a hula grass skirt. I think it's going above and beyond the call of duty like this that can really yield some exceptional results. They also had many other initiatives like front desk competitions to collect email addresses, and they involve patients in some of their initiatives too. A slightly different approach here from Derry Medical, a family practice office in New Hampshire with about 25 providers. They created the role of a portal guru, somebody in their office who any staff member could go to with a portal question and was familiar with exactly how it worked. They also actively marketed the portal and encouraged portal use for their patients every work day. And they've seen a real increase in online registration and a big increase in the number of online forms that were completed. And that's an example of patient action there. as obvious as it may be, don't forget to market the service to your patients. Here are some examples of the kinds of materials that can be used in the waiting room, or stuffed into billing envelopes, or lab results that you send to the patient by mail, or put near the front desk to inform patients about online services. And here's some additional ideas that might help inspire you, like setting goals or specific practice targets for sign-up, and collecting email addresses, for example, and setting those goals for every individual practice employee. Some of our clients have found some success with changing the tenor of the registration by something as simple as asking or inviting patients to join versus asking, have you registered yet? Just a slight change in the way the invitation is placed. And others have tried to get practice investment by having some pop quizzes around portal features and functions. How does a patient sign up? How do you reset an email account, for example? I think there's nothing quite as demotivating for patients if they come in and ask a portal question at the front desk and no one knows really what they're talking about. So encouraging everyone to be up to speed is key. Well, that's about it. Here's a light view, Dr. Jones, proving that anybody can use the web. The final takeaways. I think achieving the meaningful use 2 patient access and patient action thresholds are achievable, but it takes practice commitment and enthusiasm to get patients active and engaged. And more importantly, it does take some time to get enough patients registered and invested in online communication to comfortably hit these measures. And you should consider starting sooner rather than later to get there.
All right. Well, thank you very much, Dr. Warwick and Jean, for quite a bit of information. What we'd like to do now is transition over to the end of the session, where we're going to do a little Q&A. So if you have not at this point sent in any questions that you have on your mind, feel free to do so. We'll certainly try to get to them. If we do not get to them, again, we'll respond back to you as quickly as possible. So let's go ahead and jump into the first question. And first of all, thank you all for submitting questions. We have several to get to. So first question that came in that we want to try to address here is, what growth in registration should you be seeing if you want to be able to certify for Meaningful Use 2 in 2014?
Okay, I'll take that. Thanks, Corey. So as we presented, we think somewhere between 20 and 40% of your patients should actually be registered on the portal to help you ensure that you comfortably meet the patient action objectives and can attest at the end of 2014. And one of the things about that period is it's defined by quarters. So you want to try and get that number at the beginning of the quarter of your measurement period so that you're sort of going in fully loaded, so to speak. If your portal participation is lower than that at this time, I think a sort of guidance would be that a 3 to 5% increase each month is possible, and work backwards from your elected start date, and that might give you some indication of when you should have your processes in place to try and stimulate patient engagement.
All right. Well, thank you for that answer. Let's look at the next question we want to address here. Number 2 is a question came in. We have an elderly population. Are these patients really going to communicate online?
Well, I touched on this as well. People keep asking this question, and I think it's for good reason. It seems like the elderly are somewhat technophobic, and there's certainly a subset of people who have bypassed the technological revolution. But actually, there's a surprising amount of usage in the 60 and over age group. And many of the elderly, I guess that's elderly, have embraced the convenience of online access to many things like banking and other services, and there's been quite a steep adoption there. So I think increasingly seniors are online, and that there's certainly enough of them online to meet these performance thresholds for most practices.
Very good, thanks. Third question, what will be the most difficult patient engagement metric to achieve of the ones presented today?
I think that the most awkward of the metrics is the transmit requirement. That measures a patient transmitting personal health information that they've received from their doctor to another doctor. As Jean indicated in her presentation, it's just one of 3 qualifying activities in the view, download, and transmit category that do count towards the 5% patient activity metric. So my guess is that we'll see transmit having the lowest contribution nationally.
Okay. And the next question, some EHRs or EMRs already have a portal. Does this work to achieve meaningful use too as well?
Well, any portal that is certified as a module or together with the EHR is certified as a complete EHR is usable, and there are certainly many options. There are some nuances in the way that different portals work and how easy they are to use by patients, for example, and whether they've got some features like mobile, for example, that might really stimulate patient engagement. So I think usability and actual mechanisms like how do patients get invited and register are very important distinctions between portal functionality. And I think it's, I'd encourage listeners to really try out what they have and see how they think it'll work for their practice.
Okay. All right, well, let's get to another question. Will a portal automatically send a CCD to a patient, or does a patient need to be registered first?
This is actually a complex question. Typically, on many portals, a patient would have to be registered to receive something. And this would make it difficult to meet, or more difficult to meet the 50% requirement threshold, because at least 50% of patients would need to be registered in order to achieve that goal. But here's the subtlety. Some portals, like the Intuit Health portal, for example, does allow an EHR to send a CCD to a patient who is not yet registered and hold it in a kind of a holding account until they do. And this is important because even if they don't access it, the fact that you've posted it would count as a valid attempt to provide access, assuming that the patient is encouraged to get access and given a chance to register as well. So in fact, with our solution, sending the CCD to a patient would trigger an invitation for the patient to sign up to the portal if they hadn't got an account already.
Okay, great. Here's another question that came in. Will a provider at year 2 of stage 1 in 2014 be able to report with stage 2 requirements instead?
Each person needs to go through 2 years each stage. So you'll have to do 2 years of stage 1, 2 years of stage 2, followed by 2 years of stage 3. The thing that we mentioned about 2014 is that if you're in your second year of stage 1 during 2014, you only have to do a 3-month quarter as opposed to a full year. That would normally be the requirement.
Okay, great. So here's another question, maybe similar. I am attesting this year for 2012 for a full year. So 2013 is what, 90 days or a full year again?
2013 will be a full year.
Oh.
But 2014 is your only exception.
All right, here's another great question. Is this for only Medicare and not Medicaid?
No, the Meaningful Use Program is for Medicare and Medicaid, and then both for eligible providers and eligible hospitals. And there's quite a lot of definition around each of those categories. So certain providers can qualify for either the Medicare program or the Medicaid program. We've only covered the Medicare program here today. The Medicaid program is similar but not the same. It's got slightly different dates and slightly different payments, and possibly the subject for another webinar.
And you can only be registered under one program at a time.
Great.
Gotcha. All right. Well, we still have time for a few more questions. This question is, the problem we have is we work in a network with many physicians part-time. They are not able to answer messages timely, and some do not want to use the portal at all. What would you suggest in a situation like this?
Well, I think, again, it's a time of change. So helping those providers understand the impact of not responding in a timely way and not using the portal, and its potential impact on their Medicare earnings on a go-forward basis may be a way to try and get them more focused on participating. Hopefully, this presentation today also encourages practices to recognize how important it is for providers to participate and what their role is in both motivating their staff and their patients. So hopefully that message can be communicated as well. The part-time message is a more difficult point because it depends how much part-time. And it's been explored in quite a lot of detail, and I've encouraged the question asker to actually look on the ONC message boards and FAQs, because you can assimilate your data from different sites, but you can also submit from your majority site. And again, there's some exceptions to how that is done. So that might be something to look at.
All right. Well, it looks like we have a follow-up question from one of the points made throughout the presentation. Gene, maybe you can tackle this one. It says, could you elaborate more on the direct email option that you talked about? Does the patient direct email the caregiver's EHR messages, or do they email the caregiver at their internet email address?
Yeah, that's a good question. Direct has definitely been one of the more challenging items to get implemented, and we know it's going to be confusing for people initially. People need to understand what a direct address means. Patients aren't initially going to know what it means, and I don't think physicians and practices are going to know what it means, but it is a very specialized address. It looks like an email address. The domain portion of it usually will contain the word direct in it. So let's say Dr. Jones at directcardiologist.com to try to signify that it's this special type of address. But initially, until this project gets more traction, the patients and the physicians are going to have to communicate with each other whether or not they have one of these specialized addresses.
Yeah, could I add a couple of thoughts there? So direct, the requirements in Meaningful Use to use direct are particularly around provider-to-provider messaging, not so much around provider-to-patient messaging. So a secure portal like the InterHealth portal, where we have secure messaging, is a fine mechanism for sending secure messages from a provider to a patient. You don't have to use direct for something like that. But EHRs that are Meaningfully Use certified will have the capability to send what's called a direct message from one provider to another provider using the direct addresses that Gene just talked about. What Gene's point was in the presentation about our use of direct is that for the transmit component of Meaningful Use 2, there's a requirement that patients could send a copy of the CCD that they have in their possession to a third-party provider, i.e. somebody outside of the practice. And being that that third party would not necessarily be on the Internet Health Portal, the mechanism that we're using, the mechanism that we're leveraging is direct, so that patients could type in the direct address of that third-party provider and send the message securely that way. And it's for all that complexity is why I said that part of the engagement criteria is probably the hardest one for people to it's the one we'll see the least activity around, but fortunately it's bundled with view, download, and transmit, so it's not separately measured. So hopefully that answers the question.
Well, great. All right, well, here's a good one. How are clinics dealing with the IT needs of patients? So I'm assuming the question is related to patients trying to absorb this new technology, and they're struggling, and now that's created an additional job almost for the practice, it sounds like.
Yeah, that's a great point. And you know, one of the things, this is going to sound a little bit more like a commercial perhaps, and so apologies for that, but one of the things that Intuit brings to the picture is a very consumer-focused perspective on things like ease of use, accessibility, access, and so on. So I think it's a great question. You want to have registration, password, first use, ease of use components to your portal technology. That said, there's always going to be patients who have questions or patients who don't understand things. Again, I think some marketing materials could be useful, some summary documents. One of the things that the listeners could do if they're using the Internet Health Portal is we've got on the next slide actually some contact information, and you could reach us at that address, and we could maybe help provide you with some materials to provide your patient base.
All right, great. Here's another question. Lab results seem like a great idea, but we're a dermatology practice, and we do very few labs. Does the information sent to patients need to be structured data? Could it be as simple as a recall reminder or blood pressure, weight, something from a recent visit?
The requirement is that, well, it depends which requirement we're talking about, but PHI that's in a CCD, examples are a clinical summary from the last visit. So simply a note from the last visit, what the visits contained, maybe what the diagnosis was, if there was a medication or a cream. That would be a qualifying, that would then formed as a CCD and sent to the patient would be a qualifying count for patient access to data. So that's an example of the kinds of patient access. Certainly lab results are. So I think it's just clinical content that can be contained within a CCD, and that includes summary notes. So dermatology should be fine.
And patient reminders, they mentioned patient reminders in there, and that's a whole separate meaningful use 2 item, is to remind patients for follow-up visits, and that would just simply be a electronic text document, a secure message sent to the patient. So those don't need to be structured data, but the visit summaries would be required to be structured data.
Okay. Here's another question. Is downloading and then filling out and bringing registration documents into an office visit sufficient for participation, or do the forms need to be filled out and sent online through the portal?
The view, download, and transmit requirements, I'm assuming that's what's tying it together, they're very specific to the personal health information that has been sent to the client, to the patient. So if you send them one of these CCDs, and they view, download, or transmit that information, that's what counts in that bucket. Items like forms and things like that are a completely outside perspective from this.
Right. They do not count. So that example would not count towards the view, download, and transmit count.
All right. A couple other questions. And to meet Meaningful Use 2, we have until the end of 2014 to have what, 50% or 5% met?
So for we covered a couple of objectives. The timely access objective has got two components. One is that 50% of your patients have timely access to their patient health information, and there's a requirement that 5% view, download, and transmit. So those are two measures under the same umbrella, and both have to be met. Then there's a separate measure, a separate objective, which is that 5% of patients have to send a secure message. So that's a separate objective, and it's the patient action there is for a patient to actually initiate. That means initiate. Well, it means send a secure message. It could be in response, but it has to be at least a patient action that triggers the message. So there really are three things there. Just to be clear, for 2014, you can do it for the whole year. You have to do it for at least a quarter, 90 days, so you can start as late as October. And in order to attest, you would have to demonstrate that you meet those three different measures that I just touched on for the patient engagement criteria.
All right, great. Well, looks like we've got time for a couple more questions. Here's a good one, I think, for clarification. We've covered a lot of terms, so let's see if we can clear this up. What is the difference between a CCD and a clinical summary?
Okay, that's a good one, and it's an easy one. A clinical summary is a type of CCD. So think of a CCD as sort of a rule set, and you can send different types of items under that structure. So a clinical summary or a visit summary, those are all types of information that can be contained within a CCD document.
All right, and then I'll ask, here's one other question that was an interesting one. I think this is probably good for Dr. Warwick. What do you think about this? Do you have to have a website and portal? Is that advantageous or necessary?
Do you have to have a portal?
A website and portal.
And portal. Well, the requirement, I think the answer to that is actually no, but, here's the but, you have to have a place that you can send a CCD to, and where your patient can pick that CCD up. So, the fact that you've just created a CCD and have it resident on your EHR doesn't meet the patient access requirement. In order for a patient to be able to access it, you've got to put it somewhere that's accessible, and an easy and the typical way to do that is via a portal. So the patients have access, secure access through a password, and the CCD has a place to reside, i.e., it's waiting in the patient's inbox for them to log on. So that would be a location for that CCD. So there are probably other ways to solve this. So, for example, you could have a standalone PHR that you found a way to send your CCD directly to that the patient had, and therefore bypass those things. But I think that many of the other approaches have more complexity to them.
Like reporting requirements.
And Jean makes a great point that ultimately you need to be able to report, and when you do the attestation, you have to report on how you've achieved these things. And so having a structured system like a portal that can count every message that comes in and goes out and present those back to your EHR for your combined kind of reporting, I think is going to be very helpful. If you try manually to kind of work around those, you're going to have to work out a way to count the activity as well, which I think could be a burden.
Okay. And then just one final question, and I think we'll be just about out of time. And this question is I guess probably a pretty big layup for you, Dr. Warwick. Does Intuit have any promotional materials for posting info in the waiting room about Portal?
Thank you, Corey. Yes, we do. In fact, it's not at all lightheartedly that I respond to that, because it's taken us some time to realize how important that is. And so we've made a big effort over the last year to pull together marketing materials, put them in a package with explanatory, comments, and make those available for our clients. But it's a very important thing to do. As we talked about in the presentation, envelope stuffing with invitations, with outlines, putting posters up in the waiting room, even in the doctor's offices. I think all of those little touches make a difference. And again, this email address or phone number, please call those if you're looking for access to those materials.
All right. Well, this concludes our time this afternoon. First of all, I wanted to thank our presenters, Dr. Warwick Charlton, as well as Jean. We appreciate the input that you provided. We also want to make sure to remind everyone that if you haven't gotten your questions answered, we'll certainly do our best to follow up with you to get you back your answers, as well as we will be posting this recording and making that available to you all shortly following the meeting. So thank you very much. Please take just a few moments, if you would, and tell us how we did, and so we can continue to improve. And on behalf of Intuit Health, we hope you enjoyed the webinar. And this concludes our time. Enjoy the rest of your week. Thanks, and have a great day.